Thanks, Dr. Black, and thank you, Dr. Dowdek, for helping me out with this presentation. So we'll be focusing on the new and evolving diagnostics in renal cell carcinoma. So the objectives of this presentation are to define the current diagnostic challenges in RCC, as well as the role of molecular imaging.
Recording in progress.
And then we'll also review the role of ctDNA in the diagnosis and monitoring of RCC. And before we continue on this presentation, I do want to highlight that this presentation is mostly focused on localized and small renal masses, but these diagnostics that we're going to be talking about tend to overlap in the advanced disease space as well. So we'll be talking about that where applicable. And also want to keep in mind that, when we talk about small renal masses, it's not only about the lesion being benign or malignant, but also it's important to have an idea if it's a lesion that is mostly indolent or if it's one with an aggressive course. And that usually can really be determined by histology and grade. So to give a bit of background, in 2025, 9,100 Canadians were diagnosed with kidney cancer of some sort, whether it be RCC or upper tract urothelial, and just under 2,000 people died of the disease. Kidney cancer accounts for 5% of newly diagnosed cancers in men and about 3% of newly diagnosed cancers in women. Overall, in terms of histology, the majority is clear cell RCC, with about 25% being non-clear cell RCC. You can see on the table on the right-hand side the different histologies based on the 2022 WHO classification, which has been updated, and their associated incidences. You should also know that about 10 to 25% of small renal masses end up being benign on final histology. Pathology, I should say. So the first part of this talk is going to focus on the currently available imaging modalities in the diagnosis of RCC. So ultrasound is oftentimes the first imaging modality that patients have done, and it diagnoses about 60% of incidentally found renal masses. Contrast-enhanced CT is the gold standard used for characterization of renal masses, but also for staging. And then MRI is often used as an alternative when CT is either contraindicated or we need really good assessment of venous involvement. Finally, contrast-enhanced ultrasound is a newer or emerging modality that has been utilized in the assessment of indeterminate lesions on conventional imaging, as well as post-ablation surveillance.
Emerging for at least 20 years.
Well, yes, that's true. There's not great literature on it, but we'll talk about it. So first, conventional imaging is widely available, very cost-effective, routinely utilized for surgical planning and surveillance of renal masses. It doesn't utilize any nephrotoxic agents or ionizing radiation, and it reliably differentiates solid masses from simple cysts, and it can identify features that are associated with malignancy, like thickened walls or septa, and it can also sometimes determine on Doppler if the solid mass has vascularity. When compared to CT or MRI, though, it is inferior at characterizing masses. And Sadea and colleagues reported a sensitivity of 73% and specificity of 89% at detecting indeterminate masses initially noted on CT. And like with any modalities, obviously it has limitations, and for conventional imaging, it can't characterize benign from malignant in terms of masses, and it's also often limited by the patient's body habitus or if there's any bowel gas in the window in question. And of course, because it is operated by us humans, it can be operator dependent as well. So when it comes to CT imaging of renal masses, the preferred protocol is multiphasic CT contrast. The figure on the left is actually courtesy of Dr. Daudek, and really highlights that despite the different phases, the attenuation between benign and malignant lesions can be very similar, which explains why it can be so difficult to distinguish one from another just based on imaging features. Anywho, the multi-phase protocol usually will include an unenhanced phase, which gives you a baseline enhancement measure, and it can also detect macroscopic fat and calcification. Then around the 40 to 90 second mark, there's the corticomedullary phase, which allows for optimal visualization of the renal parenchyma and intralesional vascularity. And finally, there's the nephrogenic phase, which is best at detecting small renal masses and enhancement of those lesions. And some protocols will include also a delayed phase to assess the collecting system, but this is not something that's standardized across protocols. Thin section acquisition is also important because it allows for optimal characterizations of lesions. And in terms of its diagnostics abilities, CT performs generally well in the overall diagnosis of renal masses. Now, in terms of the advantage and limitations of CT imaging, CT imaging is widely available. It's quick to obtain, but it also offers excellent spatial resolution, which is very important for operative planning. It's also superior at detecting calcifications when compared to MR. And then, so those are the main advantages. And then for the limitations, it can't really reliably identify benign solid masses from malignant ones. For example, oncocytomas can enhance very similarly to RCCs, as we saw on that graph previously. And it can also be hard to reliably identify lipid-poor AMLs. Pseudo-enhancement from the adjacent parenchyma can also simulate enhancement in smaller masses, which is another issue with CT imaging. When it comes to papillary RCC, about half of the lesions will show absent or indeterminate enhancement, which is obviously an issue as well. And then finally, CT is associated with higher radiation exposure and nephrotoxicity in some patients. When it comes to MRI imaging, a multi-parametric protocol is also preferred. And you can see kind of the characterizations based on the faces on the right-hand side, also courtesy of Dr. Daudek. So the T1 weighted phase allows for microscopic fat detection, and T2, on the other hand, allows for really high signal intensity characterization of cystic lesions. DWI is best for tissue characterization, and multi-phase with subtraction images improves the detection of subtle enhancement, which is important, especially in CT undeterminate lesions. For MRI, the optimal enhancement threshold is 15%. And in terms of its overall performance at distinguishing RCC from non-RCC benign lesions, it does quite well with sensitivity ranging from 80 to 88 and specificity of around 90%. So MRI can be used to further characterize CT indeterminate lesions, as I just mentioned. And to facilitate this, clear cell likelihood score was developed. The way that I think about this is almost like the PIRAD score, but for clear cell RCC in MRI. And depending on the lesion's characteristics, which you can see here in the flow chart, you'll be giving a score of 1 to 5 to a lesion. A score of 1, or CCLS of 1, means that the lesion is very unlikely to be clear cell. But a lesion with a CCLS of 5 is very likely to be a clear cell RCC. There are some scenarios where MRI outperforms CT in the diagnosis of RCC, and one of these scenarios is for papillary RCC lesions. So half of the lesions, as we mentioned earlier, are either absent, have either absent or indeterminate enhancement on CT, and this can persist for some lesions in the nephrogenic phase as well. On T2, in the MRI phases, papillary lesions are hypointense and homogeneous with low enhancement. And MRI in general has been found to have high sensitivity and specificity in differentiating papillary RCCs from other renal masses, as you can see from the forest plot on the left-hand side, sorry. What you should know about papillary lesions and MRI is that papillary lesions can have hemosiderin deposition, and when these levels are high, it can completely mask enhancement on MRI for these lesions. The other scenarios where MRI has been proven to be superior to CT is with smaller masses, less than 1.5 centimeters, because in MRI, pseudo-enhancement, which we talked about earlier, is not an issue. MRI is also more sensitive to enhancement than CT, which can help characterize CT indeterminate lesions. And finally, in larger lesions where venous assessment and assessment of tumor thrombus level is very important, MRI is the preferred modality. Sorry, yeah, Dr. Forbes?
Quick question for you on that front. Are the lesions that don't enhance on MRI the same as the lesions that don't enhance on CT?
Not always. Yeah, not always. And so for assessment of venous involvement, it not only has demonstrated higher sensitivity for the detection of tumor thrombus, but also a higher agreement with surgical findings regarding the tumor thrombus level. In terms of overall performance detecting benign versus malignant lesions, MRI has a higher specificity than CT imaging. It's not limited by pseudo-enhancement. It does offer excellent soft tissue contrast for characterization of hemorrhagic and proteinaceous cysts. It doesn't utilize ionizing radiation, and it can be used to better characterize indeterminate lesions. But like any other modalities, it does have its own limitations. It struggles with detecting calcifications, and it also takes longer to obtain, like as in the examination takes longer, but also in our Canadian system, it is harder to access MRIs. Its ability also to distinguish oncocytomas and lipid-poor AMLs from RCC is also limited, and it's also very susceptible to motion artifact during the study. Contrast enhanced ultrasound has been gaining some traction in RCC as a potential modality to assess lesions. It involves the intravascular injection of microbubble contrast that have an outer shell, which is a surfactant shell, and a inner gaseous core. Because of their mechanical properties, the microbubbles allow for continuous imaging and really high temporal resolution. And CUS only displays vascular tissue, which is key in identifying renal masses. It also allows for the differentiation of solid tumors from complex cysts and pseudotumors. It's also better at characterizing images, or has been used to characterize images that are indeterminate on conventional imaging. And it's a safe modality in terms of it doesn't use ionizing radiation, and the outer shell of the microbubble is metabolized by the liver, and the gas is basically breathed out by the patient. When interpreting contrast-enhanced imaging, there are two phases. So the arterial phase occurs really quickly within the first 10 to 15 seconds and lasts for about 40 seconds. And then you have the medullary phase. For pseudotumor, you'll see enhancement of the pseudotumor. You'll see that it's identical to the surrounded the surrounding renal parenchyma and all of the faces, whereas for true tumors, the enhancement will be different in at least one of the phases. So practically speaking, this is an example of a right renal mass that was detected on MRI in a 55-year-old patient with ADPKD, and they have a contraindication to contrast agent. And on the right-hand side, you can see conventional grayscale ultrasound as well as CUS. And in the CUS imaging, which is the orange, you can see that there is a bright enhancement of the mass, which is suggestive of vascularity within the mass and therefore can be suspicious for malignancy. Final pathology for this was found to be clear cell. In terms of the overall performance, the next couple of slides will just compare the CUS to CT and MRI. So Zhang and colleagues performed a meta-analysis where they pulled data from 22 studies, and they found that CUS had a superior diagnostic sensitivity to CT and a comparable specificity. Zarzour and colleagues, on the other hand, performed a retrospective study looking at the diagnostic performance of CUS, and they found that it was successful at diagnosing the majority of previously indeterminate lesions. Different studies also looked at its performance compared to MRI. Zhao and colleagues looked at the ability of CUS to differentiating clear cell RCC from benign lesions, and they found that both imaging modalities had comparable sensitivity and specificity at doing so. Chen and colleagues compared the ability of the two at assessing complex renal cysts and found that CUS had superior sensitivity, but that MRI had higher specificity. And Zarzour and colleagues also looked at the assessment of CUS in MRI indeterminate lesions, and they found that CUS correctly identified all of the lesions, but this was obviously a very small sample size, so that should be taken into account as well. In terms of diagnostic challenges, I think even though some of the advances on the diagnosis of RCC are exciting, there's still a lot of challenges. For one, up to 20% of the lesions resected are benign, which suggests that there is some degree of overtreatment of these lesions. To this day, conventional imaging can still not reliably identify benign from malignant lesions. And finally, we would say that the majority of patients undergo definitive management without pathological confirmation. And compared to other GU malignancies, there are no good validated blood biomarker in RCC. The imaging performance can be variable, as we discussed, and tissue diagnosis is not as accessible, and when it is, it's not always reliable at the time. So all of this could contribute as to why a management for small renal masses is broader and a bit less algorithmic compared to other GU malignancies. There are several reasons for pursuing metabolic and molecular imaging and renal masses. First, RCCs are characterized by mutations in gene involving pathways which metabolic pathways, which represent a potential avenue for using metabolic radiotracers. Molecular imaging has also the potential for helping with histological subtype determination, as well as staging and surveillance. And finally, molecular imaging can also allow for patient stratification and assessment of treatment response to target specific therapies. First, we'll talk about FDG PET. So FDG is glucose analog and the most used radio tracer in nuclear medicine. In RCC, its use is limited in as a primary imaging tool because physiologically it is renally excreted, which can interfere with mass characterization. It also has variable uptake with decreased uptake in well-differentiated clear cell RCC and increased uptake in poorly differentiated high-grade disease. Studies have looked at FDG PET as both a tool for primary renal tumor assessment and metastatic disease detection. And although it has good performance at detecting metastatic disease, sensitivity was quite marginal for primary tumor assessment. PSMA PET is also a modality that has been studied in the diagnosis of renal masses. PSMA is a type 2 transmembrane glycoprotein, which is highly expressed in prostate cancer, but it's also expressed in tumor-related neovasculature of many malignancies, including RCC, which makes it relevant here. Studies have assessed PSMA expression on RCC subtypes, and Spatz and colleague found that 3/4 of clear cell RCCs stained positive for PSMA, but Jaspitz and colleagues reported that only 2% of papillary tumors stained positive for PSMA expression. There are various PSMA-specific radio tracers, but they're often primarily excreted by the kidneys, which limits their use in the initial diagnosis of small renal masses. Ghizlane and colleagues assessed the dynamic kinetics of gadolinium-based tracer in both RCC and benign renal tumors, and they found that there was increased radiotracer uptake and slower washout in RCC compared to benign tumors. PSMA is unfortunately limited by the fact that PSMA is expressed also in the proximal tubule of a normal kidney, which reduces the tumor background ratio and can lead to an increased number of false positive imaging. Rhee and colleagues performed a small prospective pilot study assessing the ability of PSMA PET at detecting metastatic disease compared to conventional CT imaging. 10 patients were enrolled in this study, and they found that compared to CT, PSMA PET had a higher sensitivity and positive predictive value. The image on the right-hand side shows conventional CT with a small recurrent lesions in the resection bed, which is not super obvious, but becomes very obvious on the PSMA PET. System-AB is another tracer that gets taken up by metabolically active cells. It's used in other malignancies like lung and breast. And Rowe and colleagues performed the initial study demonstrating high tracer uptake from oncocytomas, but minimal uptake from malignant tumors. And Zhu and colleagues then published results of their prospective trial, which assessed uptake in benign versus malignant lesions. And they included 147 patients with histologically proven solid tumors. And they found that both early and delayed relative uptake was significantly elevated in benign lesions when compared to malignant lesions. So these images are examples of System-AB study. So the top 3 images show this right kidney with an obvious mass that is enhancing on the CT. And we can see that it has high System-AB uptake. And even though the uptake is heterogeneous, it is fairly similar to the parenchyma that surrounds it. And the final pathology for this lesion was found to be an oncocytoma. And the bottom 3 images show another right renal lesion, which also enhances on CT, but doesn't take up much of the System-AB radio tracer. And when resected, this tumor showed clear cell RCC. So before we continue on, I do want to talk a little bit about the pathophys behind clear cell RCC. So under normal oxygen conditions, HIF-alpha binds to the VHL protein, and as a result, we have ubiquitination and controlled degradation. But under hypoxic environment, the binding of HIF-alpha and VHL is is reduced or limited, and as a result, you get these HIF alpha and beta complexes that form, which then promote the transcription of HIF, which then promotes angiogenesis. In RCC, you can have loss of function of the VHL gene, which leads to the accumulation of HIF, and as a result, you get increased cell proliferation, invasion, and angiogenesis. CA9 is under normal physiological conditions, upregulated in a hypoxic environment. But studies have also found that it's highly expressed in about 95% of clear cell RCC, which means that it could be a potential target for diagnosis. This brings me to talk about PET-CT with girentuximab, radio-labeled girentuximab, which is a monoclonal antibody that binds with really high affinity to CA9. It can also be labeled with multiple radionucleotides, which is another advantage. So Digby and colleagues published this prospective study, including 26 patients with indeterminate renal masses prior to surgery, and they found that radio-labeled girentuximab correctly identified 15 out of the 16 clear cell RCC lesions using PET-CT. The same group then published the REDECT trial, which is a larger multi-center trial assessing girentuximab PET-CT as a tool for clear cell RCC identification on imaging. In this study, 195 patients were included, and all of them had already been scheduled for surgery. And they all underwent both conventional contrast enhanced CT as well as girentuximab PET-CT. And both imaging and histopathological review were blinded in the study. And they found that both sensitivity and specificity was higher with PET-CT, and so were positive predictive values and negative predictive values. So on the left-hand side here, you see a 1 centimeter right posterior renal mass, which is enhancing on conventional imaging, but also very obviously positive on the girentuximab PET-CT. And the final pathology for this lesion was clear cell RCC. On the right-hand side, you see also a mass in the right kidney measuring 1.8 centimeters, which is enhancing by CT criteria, but on a fused PET-CT images, there was no tracer uptake, and the final pathology for this lesion was oncocytoma. The ZIRCON trial was essentially a confirmatory study following the REDECT trial, and the results were very similar, as you can see on the table on the right-hand side. But the key difference here was the radio tracer that they used. So in the ZIRCON trial, they used a basically zirconium-based labeling agent, but in the REDECT trial, they used an iodine-based version of the tracer. And as a result, the ZIRCON trial demonstrated a higher tumor uptake and retention, as well as decreased signal-to-noise ratio. And you can clearly see that on image C, where the tumor is lighting up very bright, but the surrounding parenchyma is barely uptaking any of the radio label. Now comparing historic renal mass biopsy performance with a CA9 imaging performance, it's clear that biopsy can provide you information that molecular imaging cannot reliably provide you. For example, it gives us information on grading, histologic subtype, and the tissue obtained can also be used oftentimes for molecular profiling when it is diagnostic. It also has a higher sensitivity, again, when it's diagnostic. And it, contrary to a lot of the imaging modalities, it can provide you information on whether this tumor is likely to be indolent or more aggressive. CA9 provides its own set of advantages. First and foremost, it's non-invasive. It can reduce non-diagnostic rates, and it can detect extrarenal disease as well. And because of this, it has potential applications in surveillance, but also in disease, in the assessment of viable disease after systemic therapy. You should know, though, that one of its key limitations is that its expression can vary greatly based on disease grade, which in the literature, it has been reported that higher expression is seen in lower grade disease. So the last portion of this presentation is going to focus on liquid biopsy in RCC. So liquid biopsy can be simplified as circulating tumor cells and circulating tumor DNA, or ctDNA. Circulating tumor cells refer to essentially intact cancer cells that have been shed from the primary tumor into the bloodstream. And oftentimes, these cells are quite rare and of low frequency, so they need specialized isolation techniques to be detected. But on the other hand, they can provide you with valuable information on the tumor biology. ctDNA or cell-free DNA is released from apoptotic or necrotic tumor tissue. It has a very short half-life, less than 2 hours, or about 2 hours, which allows for real-time tumor burden monitoring. And the optimal specimen for this is plasma. But in the GU cancers, we've also explored the use of ctDNA from urine as well. There are essentially multiple points in time where ctDNA can be utilized in the RCC disease course. So after treatment of a primary tumor, every patient has a different recurrence risk. And oftentimes patients are stratified based on the clinical pathological characteristics of their disease. But ctDNA might be something that could be integrated into risk stratification to be able to better determine which patients could benefit from adjuvant therapy. After adjuvant treatment, ctDNA can be used as a tool for early detection before radiographic progression is obvious on conventional imaging. And finally, in the metastatic setting, ctDNA could also be used as a detection of treatment-resistant clones or targeted therapy selection and treatment response. In RCC, generally speaking, ctDNA is used to detect somatic mutations, copy number variations, gene fusion, and epigenetic mutations. But there are current challenges that are specific to RCC when collecting ctDNA. And first is that RCC is one of the lowest shedding cancers, and despite being an immunogenic cancer, it has low tumor mutational burden, which makes it difficult to detect ctDNA on mutation assays. So this study from Cochetta and colleagues looked at how well plasma ctDNA can recapitulate primary tumor genomic alterations in patients with advanced RCC. And this study included 110 patients with advanced RCC that underwent sequencing of tumor DNA and ctDNA specimens. Essentially, the MSK Impact and MSK Access platforms were used, and the Access platforms is essentially designed to detect genetic alterations in ctDNA based on around 129 known cancer-associated genes. The authors reported in this cohort that both the identification of genomic alterations and interpatient concordance were quite low. Only 24 genomic alterations were found in the ctDNA of 6 of the samples. And the intra-patient concordance of mutation in the ctDNA and primary tumor was quite low, and it ranged actually between 25 to 50%. And that applied for even the most commonly mutated genes. For example, VHL, there was also very low concordance noted there. So how do we overcome this? I mean, one of the potential solutions to overcome the challenges associated with ctDNA in RCC is to target methylated segments. So DNA methylation is an epigenetic modification where a methyl group is added to a cytosine base, and this helps regulate gene expression without altering the DNA sequence. Methylation changes in cancer, and these changes appear generally very early in the cancerogenesis of the disease. And depending on the malignancy, you'll either see promoter hypermethylation or global hypomethylation. Methylation-based ctDNA can be detected in several different ways. So first, bisulfate sequencing is kind of the traditional gold standard for methylation detection. So it converts basically unmethylated cysteine to uracil, and therefore only the methylated cysteines will remain, and then that allows for detection of the methylated segments. This technique, however, can lead to a significant degradation of the sample, upwards of 80%, which is a problem in RCC, which is already low shedding and the samples are quite small. Then we have enzymatic conversion, methylation-specific PCR, and whole methylome sequencing. These are all newer detection methods being explored, but many haven't been validated in RCC. The main advantages of methylated ctDNA over mutation-based detection are that it's consistent across patients, can be detected early in the disease course. It allows for determination of the tissue of origin, and it is stable in plasma, so it can be well preserved. Nuzo and colleagues performed a study to assess the performance characteristics of this assay in identifying early stage RCC using urine and plasma CT DNA methylation patterns. And their study included 99 patients with stage 1 to 4 RCC. They found that differentially methylated regions on ctDNA correctly distinguished RCC from controls, and that their ORAC, which is a measure of accuracy, was quite high in both urine and even higher for plasma specimens, with the value being 0.99. And you can see that on the bottom two graphs. Even though this is very promising, none of this is FDA approved. None of the ctDNA methylation assays are. And on top of that, the newer enzymatic conversion methods like the TET that was used in the study is not standardized and hasn't really been validated, which is why the transition into the clinical practice, even though promising, has been slow to take off. Next, we'll talk about minimal residual disease, which is essentially a microscopic disease below the detection threshold of conventional imaging. So ctDNA has a very short half-life. So if it's detected days after the surgery, that usually suggests that it's not from the primary. And this can happen if the primary shed CTCs before resection, if it was incompletely resected, or if there was residual disease after receiving neoadjuvant treatment. Before we continue, just want to touch base on tumor-informed versus tumor-agnostic approach in RCC. So tumor-informed ctDNA in MRD is the standard in this disease space. The first step is to sequence the tumor tissue to allow for the identification of patient-specific somatic mutations. The second step, though, is to construct a personalized panel to track the specific variants in plasma. And the goal of of doing it this way is to overcome some of the limitations and challenges associated with ctDNA, namely the low shedding and low mutational burden, but high intratumoral heterogeneity. When looking at the performance of tumor-informed approach versus tumor-agnostic approach, we know that the first-generation tumor-agnostic panels had a much lower sensitivity in RCC and detected only about 25% of metastatic RCC patients at baseline. And these numbers improved drastically with the tumor-informed approach, where the baseline detection rates went up to between 70 to 90%. So practically speaking, there's this study that was performed by Korea and colleagues where they evaluated multiplex PCR and whole exome sequencing for ctDNA detection. 42 patients were enrolled in the study and all underwent complete resection of the primary. ctDNA was measured preoperatively and postoperatively with a median follow-up of 64 months. Baseline ctDNA was detected in 41% of the patients and was found to be associated with tumor stage, tumor size, as well as poorly differentiated tumors. And looking at the postoperative ctDNA detection, they found that 8 out of the 8 ctDNA positive patients relapsed, and 16 of 33 ctDNA patients ctDNA negative patients had also relapsed, giving this test a positive predictive value on this small sample of 100% and negative predictive value of 52%. The last biomarker that I'll talk about today is KIM-1, which is probably the most promising biomarker in the advanced RCC disease space. It's a type 1 transmembrane glycoprotein that's not detectable in normal kidney tissue, but is highly overexpressed in both clear cell and papillary RCC, and it can be measured in both plasma and urine. In advanced RCC, it's been demonstrated as a prognostic factor, with higher plasma KIM-1 levels being associated with worst survival outcomes. Shilo and colleagues performed a prospective case control, including 190 cases and 190 controls, and they found that KIM-1 levels could predict RCC incidence up to 5 years prior to clinical diagnosis. And they also found that a high level of plasma KIM-1 was associated with a poor overall survival. The role of KIM-1 was also explored as a tool for risk stratification in patients with localized RCC in the study by Zhu and colleagues. In this study, they had 2 cohorts of patients, including a majority of patients with clear cell RCC. And they found in both cohorts that KIM-1 was had a moderately high OROC and could distinguish RCC from benign lesions fairly well. But they also found that a high KIM-1 value was associated with a worse metastatic-free survival and overall survival. So to conclude, CUS represents a safe and promising technology with the potential to help in the diagnosis of small indeterminate renal masses. Molecular imaging with CA9 and SystemAB provides biology-driven mass characterization, potentially reducing unnecessary interventions, which is one of the challenges we have right now. And liquid biopsy can also detect early recurrence, help in treatment monitoring and biomarker-guided therapy. And finally, clinical translation does require prospective trials and validation of biomarker guided therapy to improve outcomes, along with better assay standardization. Thanks.